Morning. I'm going to talk to you this morning about ultrasound-guided sciatic nerve blocks. My name is Mitch Fingerman. I'm the Division Chief and Fellowship Director for Regional and Ambulatory Anesthesiology at Washington University in St. Louis, Missouri. The outline for this talk, we're going to talk about principles of ultrasound-guided success, the applications of the sciatic nerve block, as well as some applied, gross, and sonographic anatomy. We're also going to talk about two distinct approaches to the ultrasound-guided sciatic nerve block, the subgluteal sciatic nerve block approach, as well as the popliteal approach, mainly the lateral popliteal approach. Any talk that I do on ultrasound guidance involves 10 points for success. The first thing we want to be concerned with is ergonomics. So you want to position the ultrasound machine, the probe, and the bed height in the appropriate positions. Optimizing that image, inserting the needle in plane, and trying to stay as superficial at first just to get oriented with the needle. From there you want to advance the needle, but only when you visualize the tip of this needle. Remember that shadows don't count. Moving one hand at a time is important because you can end up with some motion sickness for the viewer as well as the practitioner. Resting the ultrasound hand on the patient is also important just because your arm will get tired if you have it freestanding up in the air. When you can't see the needle, look down at your hands, the needle and the probe and the orientation before you decide to reposition. If you think something's a nerve, then just try to follow it proximally and distally. Very important to know your anatomy, both gross and applied anatomy, and try not to rely too much on pattern recognition. The three-dimensional and visual spatial anatomy is just as important. You can use nerve stimulator when you're starting out. It is a wise idea. Again, there are about 25% of individuals that will not get a distal motor response with nerve stimulator application. That's just something to keep in mind when you are using a co-stimulator with ultrasound. And before you inject local anesthetic in any regards, you need to make sure that you see your needle tip, be mindful of pertinent instructors, as well as do frequent aspirations and look at injection pressure and patient response, as these are both very important. The applications of the sciatic nerve block, these are what we use in our practice. The open reduction internal fixation of an ankle-foot complex, ankle arthroscopy, triple arthrodesis and foot fusions, total ankle replacements, as well as for tibia and fibula fractures. You need to be mindful of this with any mid-tibia or tibial plateau fractures because you do always need to be concerned about the acute compartment syndrome. This is often accompanied with some type of saphenous coverage block, whether that be a lumbar plexus block, femoral block, fascia iliaca, or an adductor canal. Remember, the saphenous nerve is the distal continuation of the femoral nerve. It's strictly a cutaneous dermatomal level type of nerve. So it's concerning for the medial ankle and medial calf. Lower extremity dermatomes. My background is I've spent 5 years as a physical therapist prior to medical school. So I'm really passionate about different types of applied anatomy. If we look at lower extremity dermatomes, what we're focusing on here is the anterior and posterior dermatomes of the lower extremity. The posterior femoral cutaneous invariably will be missed with the block approaches that we're describing today. In order to ensure posterior femoral cutaneous coverage, you need to do a more proximal approach, such as a parasacral sciatic approach. Again, it's variable if you'll get coverage with these type of approaches that we're describing today. The other block that we talked about was a saphenous block, which is this medial ankle and medial calf that we need to make sure that we cover that when we're doing any sort of ankle or foot procedure. The functional osteotomes, there's something known as Hilton's law, where if a muscle crosses over a joint, the nerve that supplies that muscle will also supply some innervation of that joint, known as a sclerotome. So for example, the sartorius is innervated by the femoral nerve. In this regards, the femoral nerve attaches at the anterior superior iliac spine and attaches to the medial tibial plateau, the pes anserinus attachment to be exact. There is some innervation, obviously, of the hip because of its innervation of the sartorius, which is crossing over the hip as well as the knee joint. For true coverage of the lower leg, the majority of the osseous coverage is from the sciatic nerve. The anterior tibial tubercle is covered by the femoral nerve at L3, L4. But if you look at the posterior aspect, it's mainly an L4, L5, and S1 coverage. But for something like an ACL repair or a proximal tibial, like a tibial tubercle osteotomy, you can just do it strictly with femoral nerve, pending that they are also mainly in the anterior distribution of the pretibial compartment. So there's a lot of decisions that you need to make when you're deciding on a sciatic nerve block. There's a classic or Labat approach, which everyone's very familiar with, parasacral, Mansour. Again, this list is not all-inclusive. I'm just putting up sort of the cardinal blocks that you'll see with sciatic nerve blocks. Subgluteal sciatic, which is either the De Benedetto or Franco, is also described an approach. Inferior approach, which is Dr. Raj's approach. The infragluteal parabiceps approach, the Sukani approach, as well as anterior sciatic. There's at least 3 different well-described approaches to the anterior sciatic, and lateral popliteal approach. As far as ultrasound goes, the choices are clear. The main blocks that we do with ultrasound guidance are the subgluteal sciatic approach, as well as the lateral popliteal approach. The anterior sciatic, to a lesser extent, we'll use ultrasound for. For the purposes of this presentation, I wanted to highlight the 2 most ultrasound-friendly as well as catheter-friendly sciatic blocks. You want to redo it? Sorry. For this presentation, we're going to focus on the 2 most ultrasound as well as catheter amenable approaches, the subgluteal approach and the lateral popliteal approach. The sciatic nerve block, I wanted to focus a little bit on the anatomy. This is from Moore's Clinical Oriented Anatomy. The sciatic nerve in most individuals comes out below the piriformis and above the gemelli muscles. Some patients, they have the sciatic nerve will actually come out through the piriformis. Obviously, patients can get piriformis syndrome, which would lead to sciatic components and chronic pain. From there, it traverses downward and bifurcates into the tibial and peroneal components. This is a cadaveric specimen. We've mapped out the classic Labat approaches with the greater trochanter as well as the posterior superior iliac spine. Also, the subgluteal landmarks have also been marked out here and pretty much bisecting the middle in between the greater trochanter and ischial tuberosity. From there, we've reflected this cadaver, and we have the greater trochanter as well as the ischial tuberosity. And here you can see both the sciatic nerve as well as the posterior femoral cutaneous nerve, which are already at this point separate from each other. The gluteus maximus and piriformis have been retracted. The quadratus femoris is below this nerve. So above it is the gluteus maximus, and below it is the quadratus femoris. So in this intermuscular septum or plane is where the sciatic nerve exists. Some more specific subgluteal anatomy. You can see the gluteus medius here. Here's the piriformis, the gemellus, and this is where the sciatic nerve traverses out, coming down ultimately to bifurcate. Here you can see the quadratus femoris. The quadratus femoris below it is one of the external rotators of the hip. But in this septum, in between the gluteus maximus and quadratus femoris, is where you will block the sciatic nerve at the subgluteal level. This is Vincent Chan, one of his articles published in Anesthesiology in 2006. Again, this is the ultrasound-guided approach of the subgluteal region. And you can see the greater trochanter and ischial tuberosity have been mapped out, pretty much bisecting the middle, going a little bit distal to that. Contrary to nerve stimulator approach, we don't get too focused on how far are we away from the anatomical landmarks. We just use these landmarks and then try to optimize our image in the best plane with ultrasound. This is really what we're looking at here. This first layer is the skin and subcutaneous tissue, followed by the gluteus maximus, and then here's the quadratus femoris. Obviously, you see some washout here, which are the bony prominences of the greater trochanter and ischial tuberosity. And then the nerve is in this little triangular area right here. It's not as well delineated on this image, but I'll show you some subsequent images which will further enhance the appearance of this nerve. Here you can see the sciatic nerve in a triangular, gluteus maximus again, as well as the quadratus femoris. It's important to be mindful that the inferior gluteal artery runs parallel for a significant portion of this proximal course of this nerve. So be mindful when you're injecting frequent aspirations for this nerve, just to make sure that we don't have any unintentional intravascular local anesthetic injection. Again, another picture showing the triangular nature of this, traversing through the gluteus maximus with a nice lateral to medial approach at the sciatic nerve. And we try to halo about 15 to 20 mLs on top, and again about 15 to 20 mLs on the bottom to create a nice circular enhancement around this nerve with local anesthetic. Here is actually a video clip I'm going to show you, and this is actually taking the probe from a short axis to a long axis. So we're starting with a cross-sectional view of this nerve, and then we're going to rotate that probe 90 degrees to create a longitudinal approach, almost like you do with a central line or putting in an IV with ultrasound guidance. And it's a nice technique to show the entire linear relationship of this nerve. Here you can see, and now what we're going to do is we're rotating the probe 90 degrees, and you can see that this nerve is becoming more longitudinal in nature. And you can use this to bring the nerve with a needle, go from proximal to distal or cephalo to caudate along the nerve and deposit local in a linear longitudinal fashion along this nerve. It's a nice way to place a catheter as well. Specific recommendations for the subgluteal sciatic approach. The patient is typically in lateral. The ultrasound probe, we're either using a linear or a curved array. A lot of patients I can so-called get away with using just a high-frequency linear probe. Obviously, it's going to depend on the habitus of the patient. You may have to use a low-frequency probe like a C60 probe to get a full picture of this. But usually I try to use a linear probe because when the patient is in lateral, modified Sims position with the hips and the knees flexed, it tends to thin out those muscle bellies a little bit more for me. The approach I typically teach is an in-plane approach. You can either do lateral to medial if the nerve is in a transverse plane, or you can do cephalo to caudate or proximal to distal, the same analogy, with the nerve in the longitudinal or parasagittal plane. The local anesthetic volume is typically 30 to 40 mLs. I err on the side of more local anesthetic for most of my sciatic nerve blocks. Larger nerve, let's put in as much local as we can to get better onset and density. And the needle length is typically 4 to 6 inches. Moving on to the popliteal block. The popliteal bifurcation from comparative cadaveric anatomy studies tells us that the block is typically 5 to 7 centimeters above the popliteal crease. What I find is that it's typically lower and closer to the popliteal crease than what's reported in the anatomical studies. The popliteal block, you can see that you have the common sciatic, and then this breaks off into the tibial and common peroneal nerve. The common peroneal nerve wraps around the fibular head. The tibial nerve stays along the posterior compartment, innervating the gastroc-soleus complex, as well as the toe and foot flexors. Here you can see the vasculature as part of this, the popliteal artery and the vein. Obviously, this tibial component has been transected to show you what the vasculature looks like in this relationship. Here's a cadaveric specimen that we did. In actuality, what we first did is we took methylene blue and did a subgluteal approach before the dissection just to see what the spread pattern would be like. And then you can see a very nice bifurcation. Obviously, we've splayed all the hamstring musculature out of the way. And you can see the common peroneal, which wraps around that fibular head. And then you see the tibial component. And this is where this bifurcation is occurring. In this specimen, it was about 4 to 5 centimeters above the popliteal crease. Further close up, you can see the sciatic distribution. Here's the tibial component and the peroneal component. Again, the peroneal component goes to mainly the dorsiflexors and everters of the foot, wrapping around the fibular head. It's typically a little bit more slight and more wispy of a nerve than the tibial component. The positioning and specifications for this case, for a nerve block, we typically do the patient in lateral. I like lateral positioning because it lets the nerve just relax a little bit. When we do this in supine and you put the patient's extremity up on pillows, the nerve I think of like a rubber band. It gets a bit taut, it's a little bit harder to see. There's a little bit more anisotropic features with the popliteal sciatic nerve block approach at this level. Lateral also allows you to keep your arms down further. You're not pushing the probe up like in a supine approach. With a supine approach, typically your down arm, the one that's holding the probe, will get kind of tired. If you've noticed, if you've done a lot of supine approaches to the popliteal nerve. The lateral approach allows you to drape everything out. If you're doing a popliteal catheter, you don't necessarily have to have another person help you with the probe. In addition, with the supine, aside from your arms getting tired, it's very difficult to keep the hand that is holding the ultrasound probe from getting contaminated when it's below the patient's lower extremity. The prone position I'm not a fan of just because I typically give sedation for these blocks. You don't really have great access to the patient's airway, and it's just not my favorite position for doing a popliteal nerve block. Ultrasound probe is typically linear. The frequency is typically a high frequency probe, greater than 8 megahertz. The approach that we use is an in-plane approach. You can do out of plane. It's typically done in prone. The local anesthetic volume is around 35 to 45 mLs. And like I said, like a watch pot never boils, well, a watch pop never sets up. The needle length is usually 4 inches in plane. You can use nerve stimulator if you're in doubt regarding that bifurcation of where the tibial and peroneal are separating from each other. There's been a lot of literature out there as far as why are popliteal sciatic nerve blocks so slow to set up. Recent anatomical studies, as recent as this past month in American Society of Regional Anesthesia journals, have showed us that there may be a distinct paraneurium around this sciatic nerve block at this point. So just as in the past there was a suspicion of significant connective tissue septae around this sciatic nerve at this level, but this paraneurium is what's distinct, which makes this different from a more proximal sciatic nerve block. So this extra connective tissue may explain why popliteal nerve blocks are so slow to set up. The specifications for the popliteal sciatic approach, we identify the popliteal artery, and I made an asterisk next to the vein because quite often people forget about the vein because it is being compressed, and quite often you may not see it. We catch it at the popliteal crease, and then we trace this up. Following the tibial nerve proximally, it's typically around 12 to 1 o'clock in relation to the popliteal artery, and then you want to look for the junction of the tibial and peroneal nerve components. You block that nerve either at the split or just above the split. There's been some talk lately that maybe catching it right at the bifurcation results in better onset, and these studies are being further delineated as we speak. The catheter placement is typically leaving the tip in between the two components at the bifurcation if you can. You want to really try to figure eight the local anesthetic around the tibial and peroneal components if possible. It's okay just to take it as a single nerve as well. Just what we try to do is leave it deep, almost enhancing with a multi-orifice catheter. You're trying to bathe both the tibial and peroneal components at the same time. In some instances, you can also do a selective tibial component block as well. There'll be a separate lecture in the BLOCKJOCKS series on the tibial component. The tibial component block is specifically done when the surgeon or the anesthesia provider has some concerns about a potential postoperative foot drop. You can use the selective tibial component to just take out the posterior aspect and majority of the osseous structures, and you don't have to worry about necessarily knocking out the peroneal, which would enhance the possibility of a foot drop. This is a video clip I'm going to show you. We're going to start out with the popliteal artery, and you can see the tibial component, and you'll see that we're going to trace this nerve proximally. You'll see the junction of the tibial and peroneal components here. This is obviously lateral and this is medial. So now we have a nice isolated nerve right here. Here comes the needle. Invariably, you're going to end up going through the biceps femoris, which is okay. Classically, you try to get in between the iliotibial band and biceps femoris. Again, this is pretty difficult with surface anatomy to surmise that. Now we're injecting local anesthetic around this nerve, and you're seeing a nice start of a halo pattern around here. Again, repositioning. There's a decent amount of pressure. There's the nice halo effect around this nerve, and you can see that this entire nerve has been completely surrounded with local anesthetic. Again, we try to put this catheter somewhere where it's trying to bathe both components of the nerve. This was Colin McCartney, one of the original studies looking at the lateral popliteal approach. You can see that he's mapped out landmarks. In today's practice, a lot of folks don't bother mapping out surface landmarks. They look for the best image, and that's really a lot of the upside of using ultrasound-guided approaches for nerve blocks. Again, another approach showing the peroneal and tibial, a nice little figure 8 pattern here of the tibial and peroneal components. You could see great spread around both components. Again, we see another popliteal block at the bifurcation from another patient with good haloing effect of this local anesthetic. The take-home points from this: subgluteal and popliteal sciatic nerve blocks are both ultrasound and catheter friendly. This is the main reason why we chose to focus on this for this lecture series. You want to allow enough soak time for a popliteal approach. I always tell my residents that if you're going to use a popliteal block for a first case start, you either need to have a very heavy MAC or plan on doing a general anesthetic, because unless you have a good hour for it to set up, you need more time. You need to be mindful of the tourniquet time and pain, as well as remembering to block the saphenous in order to ensure complete lower leg neural blockade for any of your lower extremity procedures. Thank you for your time.